Thank you. All right, so I know there's some really great conversations going on, and hopefully some relationships happening. So I don't want to stop that, but feel free to stand, get more food, do whatever you need to do to be comfortable. But I want to just move on to the next part of the conversation. So I want to first thank the Department of Health, the members from the Department of Health who have been partnering with us to put this together. I think this is a tremendous time in history right now in Vermont, and we are sort of making history, I think, with what we're doing with healthcare reform. And as many of you know, the advanced payment model that we have now is allowing us to really think about how we can not just do what's right for generating revenue in terms of seeing patients and having everybody come into our practices, but really thinking about what's the best thing for patients, where's the best place to get them the care that they need at the lowest cost, the highest quality possible. And so one of the things that we thought about was school-based nurses. And nurses in schools are really at that point of contact where we know kids are and where families are. And thinking about the relationships that we have with school nurses in the primary care offices, and also thinking about how we could potentially strengthen those relationships so that we may be able to do some things that are outside of the box that are really good for patients and families, maybe that cost less and are more efficient. So I asked Kathleen Bryant, who's one of our pediatric nurse practitioners, to talk about her experience working in one of the schools at a school-based clinic, just to kind of give you a little bit of a background of that work. There's other work like that going on around the state. And then I wanted to open it up really to a conversation to your point about collaboration and relationships. How can we improve collaboration between the medical system and the school-based systems, and improve communication, and really think about maybe what can we do to break down those barriers? We know there are barriers. There's all kinds of barriers. So I want to kind of brainstorm with you all about what those barriers are and how we might break down some of those tonight. So Kathleen, take it away.
So about 4 years ago, we opened up a school-based health clinic at the Berry City Elementary School and Middle School, and it's a pre-K through 8th grade school with 900 students. And we are there 2 days a week, and myself and another nurse practitioner are there. Loretta's there now. And it's just a great way to sort of bridge that gap between the medical home and the schools. And it's been super helpful for me to see my patients in the school setting, and particularly with asthma, I see kids that are coming down for their inhalers every day and wonder, okay, this kid needs better control. But one of our goals overall is how do we improve asthma rates through being there in the school-based health center, because we know from studies that schools that have school-based health centers have better rates of asthma control. Kids have fewer hospitalizations, fewer ER visits, less days that they're absent. So we're kind of working on a little project now to kind of use the electronic system that the schools use to kind of weed through the system and see how many kids has asthma, and cross-reference it with our EMR to kind of see how often they're coming in and if they're getting their asthma visits as they need to. So we're kind of trying to work on different ways for how do we address asthma and improve asthma rates for kids. So I think that's just something I wanted to make sure everybody was aware that we're doing, and there are other models similar to ours across the state, and I think that it's going to maybe be something we're working on with the Department of Health, a project to kind of continue to work on this and collaborate with other school-based health centers around the state to kind of improve the care that we provide and maybe spread the model a little bit too. And it's been great to get to know the school nurses and have this relationship that I can pick up the phone and call them now, and we found that to be really helpful. So I'd love to hear any questions you have about that and just talk more about that.
Great, thank you very much, Kathleen. So I thought maybe what we could do next is, has anyone heard of a force field analysis? It has nothing to do with Star Wars, but I thought maybe we could think a little bit and brainstorm about. I think you're all here, which is wonderful. I think that a lot of people in this room feel that collaboration and communication is a good thing. And so maybe we could just brainstorm a little bit about what are the things that promote communication and collaboration. What are the things that are maybe going on right now that you found that have been helpful, that work well? And then what are some of the things that are forces against communication and collaboration, the barriers, the things that get in the way? And then maybe once we do that, we can then talk a little bit more of just like out of the box thinking about things that maybe you've thought of, telemedicine or iPads or things that we could potentially use in the future. So we'll do strengths or forces for, and then barriers or forces that act against. My handwriting is not very good. Does anybody want to start with something that they've observed or?
Our number one barrier for being able to communicate with school nurses is not having a release.
Not having a release for information. Okay. No release. So has anyone else found that to be a barrier? And so we see that both in the practices and also in the schools.
Also, not knowing what time to call. We're there during school hours, but we're not sure when the providers are available.
So when to call the provider. Because right now a lot of us don't have any time out of our schedule carved out for phone conversations and those kinds of things. So it can be really challenging.
Just a strength, where I work with Randolph and Brookfield and Braintree, we meet with a pediatrician out of Gifford once a month for an hour. So all the school nurses in our little district get together and have 1 hour per month with a pediatrician, and we find that all very helpful. Some of our kiddos have releases, and sometimes it's just nice to know what you're seeing in the office or asking different questions, and I find that extremely helpful.
Logistically, where does that take place? Is that
So-
at the school?
This pediatrician comes to one of the elementary schools.
Okay.
Yep, and the pediatrician flip-flops between, there's two that are doing this, and they alternate who comes. Yeah.
That's great. Thank you
Yeah.
for sharing that.
Yeah.
I find one of the things is that, students will come in the morning and they'll bring in a new inhaler with absolutely no information, and then I'll call the doctor's office asking to get information, and sometimes it's a couple of days later before it's actually gotten faxed to me, so that I know exactly when they're supposed to be getting the medication and why.
And to add to that, it might be from like an urgent care visit, and it's like for a short duration illness, and they're doing it every 4 hours until it runs out. There's no, and so in the discharge information just doesn't even say anything about it. So they'll come in and say, we got this inhaler, so do it every 4 hours until death do us part. And we know that that's not right. But calling it urgent care, or if we're using the right term for express care, you might not get the same provider. You might not be able to really get the gist of what actually occurred. It makes it tough.
Yeah. And do you find that sometimes those patients may not even have a primary care person? Or?
Yeah, that might be part of it. Or, and sometimes it is on the weekend, and so they went there, but then they don't even, and then the person that received that, the family, doesn't communicate that necessarily with the doctor either. And I know that may or may not get transmitted within the record, depending on if it's part of the UVM, CVMC network versus a private practice. And it gets lost in translation. But seriously, they'll just do the inhaler every 4 hours, and they just don't think it ever ends.
Yeah.
So just a point of clarification, when somebody brings something in like that, it's just it's an albuterol?
Yeah.
Right? Is that
Yes, that's correct.
Yeah, okay.
Yeah.
I'm a sports medicine doc in Waterbury, And we've been working with Spalding and U32 in particular with their athletes. At the beginning of the sports season, they've been signing a release so that the athletic trainer has, so that it gives the AT permission to talk to us. And so it's been systematized to actually have those releases on file at the school. And if we could work on doing a similar release just across the schools at the time that the schools do signing, then you guys have that form already.
But don't you guys have that form? Like school nurses, like when the parents fill out the paperwork, there is a line where they sign and say there's permission.
Yeah.
For the PCP, we have.
Right, right, for the
So you guys already
PCP.
have that, right?
But we don't routinely give that to the parents to say, take this to your next doctor's appointment. So
But if
we
you-
have it, but the doctor's office doesn't have it.
But if we know you have it,
Yep.
can't we talk to you?
Yeah.
As long as the school respects it to us.
Yeah.
Right.
Yeah.
And as long as the form is bi-directional, because some of those are written to give you permission to talk to us, but not the other way around, it doesn't release us. So the form has to be worded currently to give open back and forth communication approval, because other fact that you don't approve it.
So recommended language that we could put, that would be awesome, because then we would be able to conform that to our documents.
So this sounds like an opportunity. I'm hearing a lot of things about the release forms and just kind of thinking about some things that are working well with those and some things that are not, and maybe the potential for some kind of a work group that we put together to systematize the release forms for our region so that we all use the same thing, we all acknowledge the language works, and just get that out of there as a barrier. That'd be good. Oh my goodness, at the back, yeah.
So I'm a local pediatrician, and one thing I would like is if you all need, there's an inhaler being used every 4 hours and no documentation and it's very unclear, I would love a phone call rather than a fax, because oftentimes my faxes stack up and it's underneath camp forms and sports forms, and it's not necessarily very high. So I actually have 5 faxes on my desk that I left to come here, because they weren't, I returned my phone calls, but I'll sign the camp forms in the morning. But if you call my nurse and say, Susie Q was in the express care over the weekend, she has this inhaler, we don't know why, we don't understand, we have a release, can the doctor call back and let us know what we're supposed to be doing? And then give me a number with a confidential voicemail, so that if I don't reach you, I can say, this is Dr. Hankins, I read over the note, Susie Q should be taking that inhaler today, but I want to see her in the office tomorrow and I'm calling her parents. And then I don't have to play phone tag, we don't have to meet at the same time. If you don't understand my message, you can call me back, but usually we're good at leaving important information. So the faxes, especially a sort of handwritten note saying we're not quite sure what this is, it's very unhelpful. I mean, obviously I'll deal with it and do whatever I need to, but just a phone call saying, hey, I need to hear from you today, I don't know what's going on, much more helpful to me.
That's great.
Help me with email, because email for the nurses is secure. Fax is not necessarily.
No, it's not.
It's the other way around.
Your email isn't secure.
No, we can't use email.
You don't have any way to use provision information.
And you can't encrypt your email.
You
Well,
can.
Actually,
not easy, though.
Through SNAP, the health portal,
Pain.
that can provide an encrypted email. And Montpelier will have that next year,
But they're not,
but regular email,
but they're saying their email is not.
right.
I thought it was. If you type secure in
Right.
the subject line,
It is.
Not-
You can send a secure email from our system. It just has to be put in correctly.
I would say from that
Pound
perspective,
secure.
a phone call
It's much better.
that my nurse can flag to my
Yeah.
attention is way better than my email that I might not check till the end of the day.
That's true.
Me too.
Yeah, that's true. We're all kind of moving toward core text communication within our system, which is like a paging, almost like a paging system on your phone or a text message system. And maybe someday, that might be something that we could, if we all had the same secure text messaging system, we could communicate much more easily with each other. But- So there were a couple more questions. Yeah, Dr. Jaffney.
I just, if you want to get around the release of information, if you had a question where something didn't seem quite right and you don't use a patient name and you just want to say, I have this theoretical, I have this student and this is the situation, but not using the name, you can always get advice about a particular, whether something seems right or somebody needs more meds or whether you should suggest a control or medication to the parent based on what the clinical scenario is, as long as you're not using the name. So if you need some information quickly, but you don't want to wait for the release of information, you can always call, convey something through the phone nurse, and then somebody will get back. That it may not be helpful for the specific patient, but if it's a more general question.
And that's also helpful if you have a kid that's coming down every day and maybe I don't have permission to talk to you, if you can share with me what you're seeing, and that's just so helpful for us. And then we can call the parent and say, this is what the school nurse is reporting to us, because that release often allows you guys to talk to us. But if it doesn't go the other way, at least we're getting that information.
Yeah, and hopefully we can fix those forms maybe.
Oh, yeah.
Easy.
So I'm a public health nurse with the health department in our central office in Burlington. So I'm just visiting for the day, but I just wanted to put the plug out there. I know there are some folks in here that are on our school nurse advisory committee that actually update the standards of practice manual. So if this group as a whole comes up with some innovative strategies and ideas or sample language and things, I just ask that you consider communicating that back to Sharon Lee Treffry or through your school liaison, to you with it. But it's been a while.
Karen knows.
Yeah, exactly. Just making sure somehow that innovation gets communicated back to the people that work on those standards, because they do create sample templates. I'm not exactly sure what it says in the standards right now around the release, but we want to, I think that's important feedback for future iterations. And that's the School Nurse Advisory Committee. And Sharon Lee Treffry, the State School Nurse Consultant, chairs that committee in partnership with a bunch of great people. Helpful, are you?
Great, thank you. So I can certainly, if you have other ideas about barriers and things that are going well as far as communication and collaboration, I can add those here, but that was kind of like just an idea of something that we want to pay attention to. Are there other ideas, other things on your mind, innovations maybe that you're thinking of? And just open it up to whatever you've got.
So wellness visits, for instance, just from the standpoint of if it's done annually, we have to report to the Department of Health that they were done to all the students. And so we end up collecting that data. We do a lot of time calling back and forth, trying to get the information, either from the parent or calling the, if a child goes to get a wellness visit done, and the parent says, my kid goes to this school, and they can just fax it down. I don't know how that would work exactly, but I think it would save both sides a lot of time collecting information that we all know we want to know.
We've been talking about that, because there's no standard way in our EMR to identify what school the kid goes to, and you can't do a search via zip code because many towns have the same zip code, so we've been talking about ways to do that better.
So getting the schools, so we know where the kids are going, and then sending you all of our wellness visits. You want all the notes too, or?
No, we just need to know that
Just dreaming, yeah.
Really, it's just basically what they have done.
Notes would be great.
Well, we'll get the releases and then
The
we'll
more
send you
we know, the better.
we'll
The
send
better
you
we
the-
can take care of the
We'll
kids.
send you the problem lists and all that stuff, yeah. Please.
On that same idea, if, say, a student is seen by a provider and a medication is prescribed and it's timed to be given during the school day, couldn't the provider automatically hand a paper order to the family to then get to the school nurse and orders?
Some people do that.
Some do,
try.
yes, some do.
And the backpack.
So they could either go to the patient and family, parents, or we could send them directly to you. Okay. What else? Is anybody interested in doing electronic visits over the iPad? Yes?
Maybe they're thinking like a stress swab, like, can I swab a kid and then send, do a rapid strep test and call somebody and say, this is positive, and who's gonna order,
Yeah, I love that
Say
idea.
the
So.
parent picking up their kid and taking them to the doctor's office, and they could just pick up the prescription on the way home from work,
That's
rather than having to come with their child.
That's great. So,
Could I just put a wet blanket on that idea. So it turns out that a strep swab is only helpful if you're swabbing a kid who looks like they have strep. So if you're swabbing a kid with a runny nose and a cough and you got a positive strep, you just have a false positive. So I worry that if we start swabbing a kid who comes in with a sore throat without careful assessment of fever, yes, sore throat, yes, cough, no, runny nose, no, throat looks red, that we're just gonna be prescribing a lot more amoxicillin and not actually treating strep.
I think you could utilize us to our full licensure and give us some of those guidelines, like if this, and this, then please swab, if this and this, then you watch and read. I think that we're able to follow those guidelines. We can develop a protocol that everybody can follow.
Yeah, I think there's certainly examples of that happening all over the country, and in other countries, a lot of RN-directed visits using protocols, and I think that's a huge opportunity.
Now, one thing I'd say about that is that's going to require some work by the kind of powers that be in working on some memorandums of agreement, right? Because if we don't have MOAs with the school and we're supervising visits that are happening in lieu of our presence there and in lieu of us doing something and supervising someone over whom we do not have any kind of consulting arrangement, medical legally, that leaves us hanging out to dry. And I mean, granted, that's not going to happen that often, but you know, that kid has an amoxicillin reaction, and that calls in a script for them based on assessment of someone that I don't have a collaborative arrangement with. That really is kind of legally dicey. That could work, but we would need to get the paperwork in place to make that a safe situation.
We actually tried that in Randolph for a while, and it was, and we had a very close relationship with Gifford, so it's all overseen well. But we found that we got way too many false negatives or false positives. We just couldn't trust the test after a while. It was very expensive. So we gave it up.
Isn't there a CLIA issue too? A
You
CLIA
have to have the lab come, like we have the lab come to the school-based clinic and they check everything to make sure, so that's something you'd have to have in place.
Yeah.
But then again, that's because I'm your lab director.
Right.
Sign off.
No, I understand. You are.
Yeah.
So it's important to recognize that there's a barrier there, and I wrote it
Yeah.
down here, it's barrier.
Is it gonna be a-
We need to, see whether that's overcomable and how easy that is to overcome. But there are other types of nurse-directed visits that maybe don't even involve a strep test, but just thinking about, whether we could do any virtual visits where if we have an agreement with an RN in a school, could we do a face-to-face visit over an iPad, for example, and actually assess a child and give some recommendations? So I think there's a lot of opportunity for that in the future, for virtual visits. Karen.
One of the things that I've heard expressed a lot is just having a consistency of protocols for a number of common things. So, for example, we've adopted the asthma action plan. Doesn't need to be that. There just needs to be something as thorough as that everybody agrees on. The same thing with concussion plans and seizure plans and when can a kid return to school and to activity after a concussion. And if we could get some consistency with every provider using the same form, not necessarily the same, recommendations, but it would make things a lot simpler because then the nurses are not guessing about, I don't know this doctor, what does this doctor want me to do?
Yeah, and I think that this is a great opportunity. I'm glad you brought that up. This is a great time for us to consider this as we're coming together as a health network, and all of our practices are kind of working together a little bit more. We're starting to come up with some consistent guidelines within our practices. Up till now, it's all been kind of a free-for-all. We're all been very independent, and certainly you're going to find that there's still that streak of independence in all of us. We all know the right way to do it, right? But I think there's a lot of opportunity for us to come to some agreement around those things and then all use the same things.
Are there differences in the way, for instance, is there like the bat phone for specialists when they're calling into a provider practice? Is there, a similar kind of pathway for school nurses to be seen somewhat like as a specialist, as a peer calling a practice, so you don't have to go maybe through a longer.
The back line, yes. Yeah. Maybe I'll write that down here. Could we
One
open-
thing, though, having a school nurse, I usually just give them my direct extension instead of going to the back line and I just talk to the bus secretary. And the bus secretary, come find me. Guys, you being with the patient, saying, come on hold for the next 20 minutes, you know?
Would it be possible, just from a diagnostic standpoint, so we understand more of what needs, looking at ears and trying to figure out if a child has an ear infection or not, or at least making recommendations to a parent to take a child to see their primary care physician. It's just some tools, like Centaur, using that for strep and looking at those things. I mean, I think we try to do those things, so we're not sending someone to get a strep. I mean, some parents are like, I'm taking them to get the strep test anyway, just to find out it's negative. But if we have those and we can show that those protocols are approved by physicians or whichever, so by providers that we're following, so that when those guidelines, so we're making those recommendations, is really helpful. If an earache turns into an infection, recently most of those aren't even getting antibiotics anymore. So it's kind of like, why are we sending you? It's just so you feel better to find out you're not going to get antibiotics and take some ibuprofen or something. So anything that would give us just a way to be able to give the parents some idea that they're getting cared for, but they don't necessarily need to see, they don't need to go any further than that at that point.
I think that's a great
Without
idea.
diagnosing, I mean, we're not, from an RN standpoint, that's not what we're trying to, that's what I like to put out there. We're not trying to diagnose, but at least help to have some tools to provide that information.
Right, I mean, you're trained to do an assessment.
Correct.
So, yeah, I think it's great. So I guess at this point, I wanted to just mention that there's a lot of great ideas that I've heard today, and I want this work to continue forward, and I want us to maybe think about what next steps might be around this, and thinking that, Karen, I don't know if you've thought about this much, about whether we form some kind of a work group, or we set something up where we can continue these conversations and try to come up with maybe we work on some protocols, or we work on the release form. There's definitely some really great low-hanging fruit here, I think, potentially, that we could do.
So the school nurses, the Vermont State School Nurse Association, which is in conjunction with the National Association of School Nurses, we actually meet here at least 5 times a year. And we use the conference room, we use the facilities, which is great. And I think that could be a part of, I'm not the president, and I'm not planning on being the president, but I know that Sofal, who is the president, would totally support that. And we want that our organization, I'm on the board, and we want our organization to be where school nurses go to for information. We would also like the providers and anyone else to be able to utilize us so that we can get the same information out to everybody in the state at the same time. That communication is key. And so I would encourage us to use the VSSNA as part of that. We want to provide that, and we're still trying to figure out how we're going to do those things. And this is, I think, a great way for us to be able to do that.
So VSSNA, connect to them as well.
I believe SOAP is also on the Scores project too, so that's the nice connection there.
Because the president's
So-
always on.
Yeah, so most of the nurses here tonight are I call my nurses, so, I think it would be great if we could start to put this into motion and look at ourselves as a pilot, maybe set some of the, work through some of the issues, and then, the Department of Health is very interested in seeing how how we're gonna go about doing this, and I think that it's, the VSSNA covers the whole state, and the Department of Health has school liaisons around all of the state as well. So this could very well be sort of, the groundwork for moving this out to, to a broader audience. So I think that's something that would be very important.
Great, so what do you think would be the next step? Do we want to put together some kind of a list of people who are interested in helping with this work, that they could sign up that they're interested, or? What do you think would be the next best step?
I think that would be great. One way I just also kind of want to frame this work is that, so I now work for the Department of Health, but I was a school nurse for a really long time, so I have a hard time setting my hat aside. But I think one perspective that I wanted this group to think about is just that school nurses are chronic care managers for kids' health, and so the collaboration we're hoping to foster here is to see primary care providers and school nurses as that like continuum of care for chronic disease management for kids that are both in our practices and in our schools. And so if we could kind of come from that lens too, in that it's not just the providers talking to the school nurses, but how do we foster that continuum of care across those practices? I think that would be really helpful in sort of helping break down those barriers.
That sharing the 21st century framework for school nursing practice from NASM might be a really good thing or action step to the providers that are here today. Oh, perfect. All right, I did that. I'm sorry. Well, look at that then. It's really
So it's in the folders, is that what
yeah.
you're saying?
It'll give you a really good idea of the scope that all these folks are doing.
And I think that would be very helpful to clarify for providers, just what the, as Allison said, utilizing them to the extent of their training, which is pretty formidable, so.
Anybody not said something that they really want to say?
Can I just make a comment, since we're talking about asthma, I am in hopes that all of the providers that are here are asking questions of our at least teenage population. Because as a high school nurse in Berry, I work with students that are caught with a travel violation. And now it seems that our kids are juuling, and if you're not asked